Where's the PPT?
Sir, we are live in 3, 2, 1. We are live now, sir.
Good evening, doctors. On behalf of INTAS, I welcome you all to this live webinar on guiding principles to choose the first add-on anti-seizure drug in epilepsy management. To moderate today's session, we are fortunate to have a multifaceted and highly proficient Dr. Sumit Singh, who is the Chief of Neurology, Artemis Agrim Institute of Neurosciences, Gurgaon. He is also the Joint Secretary and founder of the Indian Headache Society, founder member and member of the Governing Council, Asia Pacific Headache Society, as well as the EC member of the INCON. His major achievements and awards are that he started the first headache clinic in the government sector in India and has also co-authored the headache management guidelines for the Indian subcontinent. He has also, to his credit, 126 publications, 24 chapters in books, and is a reviewer of Cochrane Reviews in the neuromuscular section, headache, as well as the Annals of Indian Academy of Neurology and other international journals. I call upon you, sir, to introduce the chairperson of this program and take the program forward. Thank you very much.
Thanks, Michael, and thanks again for the kind introduction. And may I now take the privilege of introducing the chairperson for this webinar, Dr. R. Lakshmi Narasimhan, a very dear friend of mine, who is
you can also be brief, Sumit, no issues.
Yes. So he is a very able treasurer for the Indian Academy of Neurology, an active member of several international advisory boards, a life member of the Indian Academy of Neurology. He has several publications to his credit, several awards. It's a long list, and in want of time, and as requested by him, I would rather be brief and ask him to take the meeting forward and introduce Dr. Sita Jayalakshmi.
Yes. It's a great pleasure for me to introduce Madam. Madam is a well-known epileptologist in the country and is nearing 1,000 of the epilepsy. So she's now 996, the nervous 996, probably really nervous within quotations, because being epilepsy, it is nervous within quotations, and has more than 100 publications, national and international journals, contributed a lot of chapters to textbooks and neurosciences, DNB teacher, PhD guide, received unanimously the boys chosen as a Moss Teacher Award by the Shine team. She is the EC member of IAN, GC member of IE, convener of epilepsy cell. More than anything, any academic matter, any time of the day, any of the younger generation can feel free to contact her. Even on any of my tough case, I will always call her and take her opinion for further guidance. She is a wonderful woman, balancing life, personal life, epilepsy, as well as administrative and neuropolitics. Over to Professor Sita Jayalakshmi.
Thank you, Lakshmi. It's always wonderful to be with you in the same platform. So I thank Dr. Sumit. Actually, he is the one who requested me, and there is nothing like request. Once Sumit or Lakshmi says, I'm always there. And I thank INTAS for considering me for this. And today I was asked to talk about how to choose the first add-on anti-seizure medication in epilepsy management. So my slides are clear?
Yes, madam.
Yeah. So this is very important topic, especially keeping the residents in mind. I have made the presentation. And all of us know from the beginning, always we say that monotherapy is always preferred. But what we do in practice is polytherapy, which is a reality. So with this, what I will do in the next half an hour is looking at the patterns of anti-seizure medication response. What are the principles for choosing the first add-on ASM? Nowadays, we should say ASM rather than AEDs, as per the new ILA guidelines. And when, which, and how many anti-seizure medications one should give during the polytherapy or add-on therapy. And what is the evidence for rational combination? Do we have enough literature to support what we are practicing? So if you look at, always we quote landmark studies by Brody et al. To know remission rates in people with epilepsy. In newly diagnosed epilepsy, remission occurs in only 68% of the cases, that is 2/3. But again, in the 2/3, around 6 to 10% do relapse in the follow-up. And we have always around 25% of the persons with epilepsy who are always non-responders from the beginning. So if you combine those who are non-responders and those who relapse, the incidence of refractory epilepsy in the population is almost just about 30%. When we come to drug-resistant epilepsy, if you see whenever a person comes with a drug-resistant epilepsy to the tertiary care units, only around 50%, less than 50% get controlled by using 2 drugs or 1 drug or sometimes in combination. But we always have around 50% of the people who are never controlled in spite of using multiple AEDs. That is, these people either have initial response or never a response or go into remission and relapse. So the patterns which occur during the anti-seizure medication will be of 4 types most of the times. The first group is those who become seizure-free immediately or within 6 months after starting the anti-seizure medication and continue throughout, means at least for next 3 to 5 years, so that we can think of reducing the anti-seizure drugs. The pattern B is they do not respond immediately, but during the next 6 months, they go into a remission. So the first group is around 37% and the second group is around 22%. But the next 2 groups are difficult to control because pattern C is where there is a fluctuation among, that is, they are seizure-free for 6 months. After that, they have cluster seizures going on for another 6 months. Again, this cycle repeats, which is seen in about 15% of the cases. And the last one is people who are never seizure-free in spite of whatever drugs we are giving. That's what we see, the people having daily seizures for almost 10 years, 20 years, without even being seizure-free for even a day or a week. So these are our real challenges before. So it's important we identify the patterns and find out what anti-seizure medication they were on at the time of remission and possibly try to add drugs to the already used drugs from which the person has got benefit. If we look at the general strategy to manage persons with epilepsy, we always say monotherapy. And if monotherapy fails, go to second monotherapy and then go to either dual therapy with 2 anti-seizure medications or use the third monotherapy. And then if it fails, again, try 2 combination therapies. If it also fails, change it into another 2 drugs or you try to combine. And if they don't do well, evaluate for a possible surgical option or a VNS. But how do we do it? Whenever we select an anti-seizure medication, we have to look at the following. Whenever we take the history from the OPD, identify what is the seizure type, whether it is a GTCS or a focal seizure, means partial becoming generalized, or is it myoclonus or absence. Then go to the epilepsy syndrome, whether we are dealing with juvenile myoclonic epilepsy or a temporal lobe epilepsy or other syndromes like benign Rolandic epilepsy. And look at the age of the patient. What's happening? Some noise is coming.
Can somebody, can all of you please mute yourself kindly? There's a lot of disturbance coming from background noise.
Yeah. So whenever we select an anti-seizure medication, we look at what is the seizure type, epilepsy syndrome, then look at the age of the person, because in children, the drug of choice in partial epilepsy is oxcarbazepine, in adults, it is carbamazepine. And then look at the gender, because women have special needs, whether they are on contraception or pregnancy, lifestyle of the person, and expected compliance. Some people were poor compliant, possibly we need to give once daily doses. And look at the drug, and that is anti-seizure medication, doses. And titration time is also very important. If the seizures are too frequent, if you use a drug which you titrate over a long period, it may not be possible to control the seizures. Look at the interactions among the anti-seizure medications and also with other drugs. Any deleterious and adverse effects are there with the medication, and any comorbidities, especially people who are obese, we should always be careful to give oxcarbazepine or valparin, because we will add to the weight of the people and add to more issues related to metabolic syndromes. And whenever we are titrating the medication, we should always see how fast we can titrate. For example, Lamotrigine takes a very long time to titrate, whereas brivaracetam can be titrated fast. Lacosamide takes medium. Levetiracetam also, if you are adding the drug, you should titrate. Otherwise, we can give a loading dose and maintain. Clobazam also, we have to titrate slowly because of sedation, which is related. Whereas perampanel takes a very long time to titrate to avoid the behavioral and other side effects. So what are the principles of choosing the first add-on anti-seizure medication? The primary goal of treatment is good quality of life, that is seizure freedom, along with no adverse events, and patient is able to do their day-to-day work normally. One should exclude the possibility of pseudo pharmacoresistance. Nowadays, we see so many functional seizures or so-called non-epileptic events, which are already on 3 to 4 types of anti-epileptic drugs. So it's important to do that much of time to identify, are we really dealing with a true anti-seizure medication resistance. For anti-seizure medications, one should prioritize the efficacy and tolerability. Choose the anti-seizure medication which is expected to protect against the individual seizure type, and at the same time should not precipitate other seizure types. For example, in juvenile myoclonic epilepsy, if you use sodium channel blockers, they may control the GTCS, but they can precipitate the myoclonus. And if the classification of epileptic events, if we are not sure whether it is what is the type, then always use broad spectrum anti-seizure medications like levetiracetam or even valparin. Then whenever you are using the first, always adding the drug, combine the drugs with different mechanisms of action, or try to use the drugs which have a synergism, and use anti-seizure medications with lower potential for adverse drug interactions. It should have a simple titration scheme, and also one should plan appropriate measures to assess the clinical response. So we cannot write medicines and ask them to come after 6 months. So we should know initially the follow-ups may be closed, after which once they are under remission without side effects, the follow-ups can be once in 6 months or even 1 year. So how do we choose these add-on anti-seizure medications? Do we have something called rational polytherapy, and how do we do it? If you look at in the past 50 years, initially we have the first generation AEDs which are supposed to be efficacious. Then we had the second generation AEDs which are important for safety. But now we have third generation anti-epileptic drugs which are supposed to be both efficacious, at the same time less adverse effects, that is, they are safe. So we should do a rational choice of first add-on anti-seizure medication. So that is when the first or second monotherapy fails, we add the drug. And before that, we look at whether the patient has non-epileptic seizures, or there is a combination of epilepsy along with non-epileptic events. Whether the patient has generalized seizures but not focal seizures, then the drug of choice will be different. And anti-seizure medication used as monotherapy was not suitable for that particular type of seizure, or the patient is non-compliant. This is more common. So always I tell my patients, if you don't tell me the truth, most of the time they deny that they missed anything. Then I'll say, I'm going to increase your dose, and this is going to be there for many years. So please just check back and let me know. Then they will confess that they missed the dose. And initially they will say once, after that it will become more frequent. So that much means we have to take them into confidence and do the interview. And in addition to this, the anti-seizure medication should be based on the neuropsychological profile and psychiatric comorbidities the person has. The 2 words like, do you become anxious? Do you sleep well? How is your mood? These things are enough to understand. So if there are associated mood disorders, we should give drugs like carbamazepine, valparin, or lamotrigine, which are mood positive. If there are sleep disturbances, one should go for clobazam, which will help them. If there is anxiety, also clobazam. If there is psychosis, better to use valparin or even lamotrigine. If there are headaches, better to use topiramate. If there is cognitive impairment, one should be careful not to use drugs which will further cause cognitive impairment like topiramate. And if there are personality disorders, one should avoid perampanel, even levetiracetam, and better to use drugs like sodium valproate. Then during the polytherapy, one should know what are the advantages and disadvantages. The advantage is potential synergism, but disadvantages is toxicity, which is either related to the combination of the drugs. We cannot combine 2 drugs which cause CNS toxicity, like phenytoin with carbamazepine, or even one should be careful about this. And unfavorable drug interactions, if they are present, better not to use them. And the factors which determine the choice of add-on drug is based on randomized controlled trials, and also combining drugs with different mechanisms of action, and those who have low incidence with no pharmacokinetic interaction when they are on other drugs other than AEDs. In reality, not all drug combinations are equal because we have more than almost 20 anti-seizure medications available and more than 100 combinations are possible. And it's impossible to try all these combinations. It takes more than a lifetime. And one should know that there are no major differences in the efficacy between the drugs, whether it is first generation, second generation, or third generation. I'll show the evidence for that later. But the major differences are there in the side effect profile. That's how the third generation are scoring over second and second over the first. And also drug interactions. So based on this, inappropriate choice of first add-on, if you do without following the background, it leads to lack of efficacy, worsening of the seizures, and increase in the side effects related to the medication. So one should understand the pharmacokinetics broadly into enzyme inducers and enzyme inhibitors. The enzyme inducers are all the first line AEDs or sodium channel blockers, and then also drugs like even lamotrigine, whereas drugs like levetiracetam do not have any effect, whereas valproate is an enzyme inhibitor. Similarly, one should know the interactions among the anti-seizure medications as well as non-anti-seizure medications before we start the medication. Sorry, I'm having some URI. And then most important is, I will say that affordability is the key. In India, we cannot use straight away the drugs which are very expensive. Always better to have a chart in the OPD on your desktop about the cost of each drug, and always ask the patient that your medication is going to cost you these 3 medicines you need to continue, and it will cost you 5,000 rupees per month. Can you afford for long next 2 to 3 years? Most of the people will say, do I have any other choice? So we have to consider this and go, because now if you see the third generation AEDs, especially the latest editions, are very expensive when compared to the second generation, which are expensive when compared to the first generation AEDs. So during the rational management, we divide the drugs into broad spectrum and narrow spectrum. The most important one in the broad spectrum are sodium valproate, even lamotrigine, levetiracetam, brivaracetam, even perampanel. Whereas the narrow spectrum drugs are the sodium channel blockers and even the lacosamide. So first we choose the drug based upon the seizure type, whether the patient is having a child infantile spasms, or if they're Aspen seizures, again the drug of choice is ethosuximide or valproate. In atonic, tonic, myoclonic seizures, it's sodium valproate. In tonic-clonic, valproic acid or levetiracetam. In focal seizures, oxcarbazepine in children, carbamazepine in adults, to which we add the drugs. And then also choose the drugs based on the epilepsy type. If it is childhood absence epilepsy or juvenile absence or juvenile myoclonic, go for sodium valproate. Ethosuximide, again, nowadays not available. Previously it was available. And neonatal seizures, nowadays we use levetiracetam. Previously it was phenobarbital. So when should we really add the drug? After the failure of one or more than one monotherapy, and we combine drugs with synergistic interaction. So what is this rational combination therapy? This is intentional choice of second anti-seizure medication to enhance the seizure control. And in this, we have a presumption that the 2 anti-seizure medications with different mechanisms of action will provide better seizure control than the 2 drugs when they are used individually. And also, than the drugs with similar mechanism of action. So normally rational polytherapy, sometimes we start from the beginning, that is on the day 1 when the patient comes, especially if there is a high seizure density, somebody coming with daily seizures, we just don't go with one drug. We add clobazam so that you reduce the seizure frequency. And also, for example, if there is a substrate like vesical temporal sclerosis, cortical dysplasia, you know that it's difficult to control, and we go for directly add-on therapy or 2 drugs at a time. And also, whenever we are adding the drugs, we should know the mechanism of action of the drugs, what we are using. I will not go into the details. This is because when you combine the drugs, you should use drugs with different mechanism of action or multiple mechanisms. So if you look at, we have sodium channel blockers. The recent addition is slow sodium channel blocker lacosamide, and we have calcium channel blockers. Only ethosuximide is being used, others we don't use. GABAergic drugs, especially benzodiazepines like clobazam, and synapse S2V modulation by levetiracetam and brivaracetam. And we have drugs with multiple mechanisms of action. That is sodium valproate. Even levetiracetam has multiple mechanisms, brivaracetam, topiramate, jonissamide, and recently perampanol. So how do we combine the drugs? The combining drugs with different mechanisms of action is superior to combining those with similar mechanisms of action. Or we can combine drugs with single mechanism of action along with multiple mechanisms of action. Different mechanisms of action means we combine a SV2A inhibitor with a sodium channel blocker. Or you combine a single mechanism, that is the sodium channel blockers with drugs with multiple mechanisms. You can still combine with valproate, levetiracetam, even brivaracetam, which have multiple mechanisms of action. And there is evidence that this is based polytherapy, that is add-on therapy based on mechanisms of action may enhance the effectiveness. And what is the evidence for this till now? So there is evidence for combining sodium channel blockers with non-sodium channel blockers. Similarly, there are randomized control trials available for carbamazepine with levetiracetam. And also levetiracetam, lamotrigine, lacosamide can be combined with each other. But one should avoid combinations with similar mechanism, like don't combine carbamazepine with phenytoin or carbamazepine with lamotrigine. So during the rational management, the greater the drug burden, the less likely will be the polytherapy to be tolerated. So one should always look at the drug burden should be less, which is a function of dose as well as the number of the drugs. So if you give him eight drugs in small doses, 4 anti-epileptic drugs, nobody will take the medication. Better to go to the maximum dose of a particular one drug and add the second drug rather than go for more number of the drugs. And this addition of second anti-seizure medication should be synergistic. Synergism means they are more efficacious with less side effects. So this has been shown extremely well with use of valproate with lamotrigine. So during the drug interactions, if you combine drugs, sometimes there is a risk of lack of efficacy, especially when you combine carbamazepine with lamotrigine, or increased or unacceptable side effects. Similarly, when you combine drugs which enhance the behavioral side effects, like combining perampanol with levetiracetam, which should never be done. So how are these rational combinations studied? That I will not go into the details, but I will show you the evidence now. What is the evidence for add-on therapy of anti-seizure medications? So the anti-seizure medications, the synergism evidence means both the drugs will increase the dose of each other, are more efficacious in controlling the seizures. The best evidence is for valproate with lamotrigine. In addition, topiramate with lamotrigine, phenytoin with phenobarbital again is one of the excellent, especially when people cannot afford the second and third generation anti-epileptic drugs. I always use phenytoin with phenobarbital. It really makes them seizure-free. Combining carbamazepine with valproate or even the other drugs. And again, most of the studies are about valproate with lamotrigine. And then whenever valproate is added to lamotrigine, if you can see, the below graph shows that it gives the highest control of the seizures when compared to adding of lamotrigine to the sodium channel blockers. The synergism is gone. Similarly, when sodium channel blockers are combined with drugs with multiple mechanisms of action, the seizure freedom is high than when compared with other combinations. Then what is the evidence for the other combinations? Like I already told, one can combine lacosamide with levetiracetam, lamotrigine with levetiracetam, valproate with levetiracetam. If you see everywhere levetiracetam scores over because of the multiple mechanisms of action, it can be combined with any drugs other than the drugs which increase the behavioral issues. Similarly, topiramate also is a very good drug. It can be combined with even sodium channel blockers, especially carbamazepine, where it has no side effects. It can be combined with levetiracetam. But however, one should avoid combining with valproate and even lamotrigine and oxcarbazepine. The next drug is clobazam, which we always use as one of the add-on drugs because of its cost when compared to other drugs as the first add-on in most of our OPDs. And it has been very well shown, even in AIMS study by Dr. Manjari and all, that it is one of the good drugs to be used as add-on drugs with more than 50% reduction in the seizures burden. And the side effects are about 1/3 of the patients. But however, clobazam as add-on treatment reduces the seizure frequency and also mostly effective in partial as well as generalized seizures. the retention rate is almost 70% at 1 year and comes down to 40 to 50% at 4 years. Then coming to levetiracetam. So if you look at most of the papers, they describe that levetiracetam has opened the door to a new and convincing treatment option in epilepsy and still remains the most prescribed anti-epileptic drugs all over the world, with a novel mechanism of action, favorable both pharmacokinetic and side effect profile, except for behavioral issues occurring in about 20% of the patients. And it has been extensively investigated in all the seizure types and both focal and general epilepsies. Whereas if you take lacosamide, lacosamide has also a very good favorable pharmacokinetic profile with rapid onset of action, multiple mechanisms of action in addition to slow channels, and it has linear pharmacokinetics and it has good cardiac tolerability, though initially it was said that it can cause some prolongation of the QT interval and also some arrhythmias. And most importantly, it has no negative effect on the cognition. So it's mode friendly. We can use in people who have even psychiatric issues. And long-term adjuvant therapy is safe and well tolerated, so can be used as first add-on therapy. And it has been shown very well during the add-on therapy. Lacosamide, the seizure freedom is very high when it is combined with non-sodium channel blockers, but also it can be used with sodium channel blockers. We do use a lot of combination of lacosamide still with the fast sodium channel blockers without much significant side effects. So it can be used in both the groups, but it scores over when combined with non-sodium channel blockers. And the responder rate is more than 50% in these cases. But however, one should always again titrate slowly so that the common adverse effects is usually nausea and vomitings and sometimes ataxia, double vision if you titrate fast, and one should be careful about that. The next drug is brivaracetam, which also has got an excellent favorable pharmacokinetic profile where you don't need a drug interaction. You can titrate fast within 3 days and it's high bioavailable almost 100%. So you can, so that the drug seizure control is fast. And when you compare to levetiracetam, it is more than 10 times more potent than levetiracetam. And it has no effect on the AMPA receptor, and hence the behavioral side effects are supposed to be less with brivaracetam. And brivaracetam can be also added as a first add-on drug. The advantage when compared to older AEDCs, it has good efficacy and safety profile. When compared to levetiracetam, it has got, again, the side effect profile is better, and hence it is also because of its ease of use and novel mechanism. In addition to SCTA, it also has multiple mechanisms of action, and hence it is supposed to be one of the good first add-on drugs. And also it can be used in special population. One can use even in hepatic impairment, but we have to reduce the dose when compared to levetiracetam. Can be used no dose adjustment in renal impairment. Can be used safely in elderly above 65 years who are on multiple medications. And in children also, it is very useful above the age of 4 years. So one can use brivaracetam as first add-on in patients with drug refractory epilepsy, or in patients who have lack of response to levetiracetam. When you switch over to brivaracetam, the efficacy increases. At the same time, those who have adverse effects also, the adverse effects may settle with brivaracetam. And in special population groups, it has been found to be useful. The final drug is perampanel, which is a oral AMPA glutamate receptor antagonist, which selectively targets the neuroexcitatory pathways. So it has a novel mechanism of action, and hence we can combine perampanel with any of the first or second or third line anti-epileptic drugs. But the important aspect is one should titrate it very slowly, start with 2 milligrams, and every month one should go to increase by 2 milligrams, reaching a target dose of 10 to 12 milligrams based on the tolerability and also the seizure freedom. Advantage is it can be given once daily, very useful in people who are not compliant. But the adverse effects, most important is behavioral psychiatric disturbances, homicidal, suicidal thoughts, and falls are also common, and one should keep it in mind. The evidence which is available for perampanel as add-on anti-seizure drug is partial onset seizures, primary generalized tonic-clonic seizures, especially JME patients who are not getting controlled. It has been found to be useful without aggravation of absences or myoclonic jerks. In children, especially when they are having multiple types of seizures with epileptic spasms, it's very useful. Even in Dravet syndrome and tuberous sclerosis. Elderly with epilepsy, but I avoid using it because of the risk of falls. It's supposed to be useful in progressive myoclonic epilepsies, post-anoxic myoclonus, Lafora body myoclonus. Then the final question is, so by adding these anti-seizure medication combinations, have the second line anti-seizure medications or newer agents have really changed the clinical outcomes? So if you look at the evidence available in the past 10 years, the commonest dual therapy regimens used are lamotrigine with valproate, carbamazepine again with valproate, levetiracetam with lamotrigine, levetiracetam again with the valproate, and lamotrigine and topiramate. And people have used drugs either in say 2 drug regimens or 3 drug regimens together, and rarely 3 drug regimens. And statistically significant combination, again time tested, is lamotrigine with valproate and carbamazepine with topiramate, which was before the this is in the when the only second generation AEDs were available. And it also was found that the polytherapy does not necessarily cause more adverse effects. So that is a very important point, because the newer AEDs are supposed to have less side effect profile, and adverse effect profile score is same whether it is monotherapy or polytherapy when they are using the second generation drugs. And then in the another important study by Brody et al., what they have done is they compared the second generation drugs like levetiracetam, lacosamide, topiramate, as well as jonismide and pregabalin, and it was found that drugs like levetiracetam, lacosamide, topiramate resulted in more seizure freedom when compared to jonismide and pregabalin. And also looking at the adverse effects, the side effects again were more with jonismide and pregabalin when compared to levetiracetam, topiramate, and lacosamide. And finally, the take-home message was that topiramate, levetiracetam, lacosamide are more efficacious and better tolerated than the other drugs, that is the second generation AEDs, which were evaluated. But however, the recent paper by Peruca in 2020, in which they have compared the seizure freedom across various periods, various decades, that is from 82 to 91, 92 to 2001, and again in the past 10 years. So the essence is, if you look at the graph, the seizure freedom remained the same over many months in those years when they followed up the patients. And it suggests that no differences in the probability of seizure freedom were apparent in the 3 consecutive analyses done in this group of patients, suggesting that the second generation or the first generation or third generation AEDs did not really make a change in the number of the people who are refractory. And then the another important aspect is women with epilepsy, they have very few choice. First option is levetiracetam always. Second option is adding lamotrigine to levetiracetam irrespective of the type of the seizure. And sometimes if they are not controlled, small doses of clobazam may be useful. And always one should keep the risk of malformations. Again, if you see the second generation and third AEDs, lamotrigine, levetiracetam, they have the least potential for risk of malformations when compared to the first generation AEDs, and valproic acid in high doses as the highest. So this one should keep in mind when we are using the AEDs. And finally, how many AEDs one should use in a patient when you are adding the drugs? Can we prevent people with drug-resistant epilepsy from receiving too many drugs? That's what nowadays is happening with the too many drugs into the market. We have a temptation to try too many drugs. So what is the evidence for this, the number of the drugs? It has been very well shown that when the second drug is always recommended, but the third drug, which helps only in less than 15% of the cases, and the fourth drug never helps. And the evidence from this comes from Stephen's study, where they looked at analysis of the seizure freedom in 2000 versus 2010. And if you see that in the seizure-free and 3 AEDs is only around 12%, which increased to 17% after the advent of the second line AEDs. Whereas seizure freedom on the fourth drug is almost negligible. So the message is one should try 2 drugs and at the maximum 3 and never 4 unless there is a real change in the seizure control by adding the fourth drug. And one should always remember that, also remember that combination therapy should not be used, especially when women are planning pregnancy. Try to do monotherapy, maximum is dual therapy. Suboptimal control of seizures is allowed. That is, if somebody is getting only jerks and GTCS are well controlled, we need not control too aggressively. Similarly, minor hypomotor seizures can be ignored. You need not unless they are disabling. And also the risk of teratogenicity is highest soon after conception and in the first trimester. And hence AED therapy should be rationalized before the conception and during the first trimester. And also one should always avoid valproate. So these are the conditions where we should really not use valproate and also use the least number of the AEDs. So finally, before closing, the important guidelines for add-on anti-seizure medication therapy is establish the optimal dose of the baseline agent, add the first anti-seizure medication with multiple mechanisms of action or a different mechanism of action, avoid combining drugs with similar mechanism of action, titrate the new agent slowly and carefully because the person is already on one drug. Be prepared to reduce the dose of original drug if finally there is a seizure control of almost 6 months. Replace less effective drug. Try the range of different dual therapies if this fails. And add a drug only if the seizure control is not achieved and adding it is helping. And devise a palliative strategy for drug-resistant epilepsy or evaluate them for a possible surgical option. So in summary, over the last decade, the percentage of patients benefiting from anti-seizure polytherapy has remained unchanged at between 20 to 30%. It was 30% nearly 2 decades ago. Now it is around 20%. Majority are controlled on 2 drugs, and most best combination and most frequent combination which has synergistic mechanism is sodium valproate and lamotrigine. And highest, very few, means around another 10 to 13% may be benefited by adding a 4th drug. And very few patients respond to 4th AEDs. And among the drugs, levetiracetam, lacosamide, and previously topiramate were most successful. But we still need time to understand brivaracetam and perampanel to use for combination therapy to know how efficacious they are because they are just recently into the market. Thank you.
Dr. Lakshmi? Dr. Lakshmi Narasimhan?
Yes, sir. Yes, sir.
Yeah, your comments, and then we'll take it up for.
As usual, a wonderful lecture.
Thank you.
Bottom line is when you choose an anti-seizure medication, Madam has elaborated all the beautiful points. But bottom line is it is trial and error. And time is not far away when AI is going to take over and more precision epileptic medication is not far off. Because the multiple comorbidities, the effective combinations, different mechanisms of actions, all these things will be given different weightages in the various neural networks, and they will finally give you at least one, or if you ask even for AI, if you ask for a combination, what would be the ideal combination? Both it is going to give. And already I saw that the recent Nature issue, there is a beautiful article on AI for and choosing the anti-seizure medication and how to choose your. That is, I think that was the first step towards. And the talk was so beautiful. Madam has included every comorbid condition. Not only that, she has covered all the special situations where you choose all these things. And I also, the need of the hour is all of us to have our own pregnancy registry for the country in epilepsy. It is highly need of the hour because lot of this data are driven by the different pharmaceutical races. And the truth is far away from it. So I would really request Madam 2022, she should start a pregnancy registry in a nationwide already there is one in Trivandrum, but it is, I don't know, it is all the centers are pooling our data. The time is there that we should be able to give the data. And the discussion, I'm sure Dr. Sumit will take you around the newer candidates in the 20 newer anti-seizure medications, the two new heroes, the perampanel and brivaracetam are the two new heroes in the field, where everything is talked about them day in and day out. And over to Sumit for further refining the discussions. And
yeah, thanks, Dr. Lakshmi, and thanks, Dr. Sita, for a wonderful presentation. You have actually covered a lot of things. There's hardly anything which is left for intricate discussion, but I think a personal opinion from all the panelists might be worthwhile. So I'll start with me. So I think that the AMPA component is a major component in deciding what not to give and what not to combine. There are three drugs which are potentially active on the AMPA. One is levetiracetam, second is perampanel, and third is topiramate. So all three of them have got significant behavioral issues, and that is why the issues related to behavioral problems, anger, and other things are a problem with all these three drugs. So obviously, it goes without saying that a combination of these three drugs in any permutation might not be worthwhile in terms of the side effect profile, even if it is effective in terms of seizure management. Brivaracetam has a one point which is good, that it is a potent SV2A ligand analog, and it is not acting on AMPA. Therefore, this drug can be a potent and able candidate for replacement of the drugs like levetiracetam whenever it is causing significant behavioral side effects. It is being promoted as a first add-on in patients with partial seizures. There are reports coming in for its use in primary generalized epilepsy. However, if we remember correctly, then levetiracetam was a panacea for all the drugs when it was released in the market. It was as if it is a wonder drug, and there is nothing which will ever beat levetiracetam in terms of its potency for primary generalized or partial onset seizures. And it is only after more than a decade that we are coming to understand of its side effects. So I think it is too early to label anything on brivaracetam and perampanel. The problem with perampanel, which I feel, is it's a slow titration. It is very difficult to titrate it on a rapid basis. Of course, we have tried it in some patients with autoimmune encephalitis on a rapid titration base, where we expect an NMDA type of a receptor associated autoimmune encephalitis, and the patient is having a new onset refractory status epilepticus. We have tried it with good results, but otherwise, it's one drug which is usually slow to be titrated. Of course, once it's given with carbamazepine, a relatively rapid titration may be possible. So now I would take my discussion on to Dr. C. Ramesh, who is from RNC Hospital, Hyderabad, Telangana. Are you there, sir?
Good evening, all.
Yeah, hi. So what would be your take on the first add-on in patients with partial seizures? And because that is probably the only point of discussion, because usually the primary generalized epilepsy require one, at the most two drugs. And most of them are well controlled. It is very, very unusual to have a primary generalized epilepsy, which is poorly controlled with medication.
Coming to the perampanel, sir, it's usually on AMPA receptors, which controls the early postsynaptic potentials. Maybe because all remaining levetiracetam and these drugs, they main actually on the late postsynaptic potentials. The titration is very slow. I tried around 10 patients as an add-on medication. Till now, the 4 mg till 6 mg I went. Whatever studies are showing, if you titrate till 8 mg, the side effect profile is more. with perampanel. So till 2 mg, 4 mg, the side effect profile is comparatively less in my practice.
Okay, Dr. Pradeep Kumar from Nobel Hospital, Patna. Are you there, sir? I think he's not there, or he's not able to connect. Dr. Nirav Mehta. Dr. Nirav Mehta from... Yeah, good evening. So I would like to have your comments in the problems which you find in patients on partial onset seizures as a first add-on, using perampanel as a first add-on. And what are the positive points which you feel about them?
See, the positive points about this drug has always been the once a day dosing, So the cost has been a plus point. The once a day dosing has been the plus point. And it has really got you out of critical situations, in patients with refractory seizures where no drugs seem to work. Adding this has helped, at least in my patients, bring down the seizure rate drastically. So that has been the main plus points of this drug. And if you talk of negative, I think the biggest negative which I have seen in practice has been sedation. And one patient I had, a young female, who actually developed some psychiatric manifestations for which we had to stop the drug.
All right. Dr. Sameer Arora, what is the major reason for you to start and stop patients on perampanel? Dr. Sameer is there?
Hi, good evening, sir. Sir, in Indian scenario, if we see as an early add-on and a late add-on, still we are not in that stage where we are using perampanel as a first add-on. Even in the recent times, we have been using either lacosamide, or the clobazam, or carbamazepine, or oxcarbamazepine as second add-on, because in general, if we see, most of the things are revolving around levetiracetam as the that is the first monotherapy that we use. And in case we require second in addition drug, we usually switch to we usually consider lacosamide, clobazam, or carbamazepine, and then as a third add-on, we may consider perampanel as a third add-on. Definitely, patients with levetiracetam and perampanel may develop behavioral side effects more as compared to the other add-on combinations. And in cases of status epilepticus, we have used perampanel because we know there are GABA receptors in such cases, and practically benzodiazepines and barbiturates are likely to be ineffective in such cases. So a drug with a novel mechanism of action like perampanel is likely to be effective, and we have seen results in our patients with status epilepticus with perampanel.
Okay. Dr. Sukriti Chauhan, who's from Sikkim Manipal University, Gangtok. Dr. Sukriti, are you there?
Yes. Actually, my experience with perampanel is like whenever we have patients who are on follow-up, and when they are already on 3 drugs, whenever I added it, it gave a good response. And then over a period of 1 or 2 months, I started decreasing the previous antiepileptics, the ones he was taking as second and third add-ons. So I made this a 4th add-on and stopped the 2nd and 3rd. And as far as I tried, one more patient who had Rasmussen's encephalitis, that particular patient had like extreme sleepiness after the drug. So the pediatrician himself just stopped it, and the sleepiness took effect within a matter of 1 day. So I would say that this particular adverse effect of getting the sleepiness was really like very fast. One good thing was patient was seizure free within that particular day also. But then the pediatrician was not very convinced about, if the child was a teenage child around 13 to 14 years of age. So they were not very convinced. So we were like, okay, fine, then you continue with your treatment plan. It was like that.
In my experience, those patients who have new onset refractory status epilepticus, particularly associated with autoimmune encephalitis. Those are the ones where the response has been rather surprising and extremely satisfying. I had a patient with Lennox-Gastaut syndrome who was on 6 anti-epileptics. He was on very high doses of sodium valproate. He was on clobazam. He was on levetiracetam. He was on Gardinal. He was on carbamazepine, and he was on zonisamide. So these were the drugs which was his cocktail for seizure control. So I did over a period of time gradually withdraw the Gardinal and also zonisamide, and I introduced him on perampanel. He did show a very good response in terms of his seizure control, but his behavioral issues became so bad that he started breaking around things in his home. So we had to retitrate the dose of perampanel from 6 milligrams to 4 milligrams. So that was one case which I often remember of significant anger issues with the perampanel.
So how long did the patient take to have this behavioral symptom? Like, was it a period of 2 to 3 weeks?
6
or
weeks.
More than that?
6 weeks.
Okay, so we shouldn't be making any changes in the first 4 to 5 weeks. That's what you suggest.
Yeah, that is advisable. That's why it is a very slow titration, which is advisable. Dr. Sita Jayalakshmi, there is a question for you from the audience, which is your experience or comments on the role of zonisamide as add-on in patients with epilepsy.
Yeah, zonisamide, like I said, zonisamide also has got multiple mechanisms of action. It has effect on the calcium channels as well as, it is similar to topiramate, to say in one word. So it is also one of the good add-on drugs, but I use mostly in patients who, similar to topiramate, it will cause weight loss as well as loss of appetite and some CNS toxicity. We should be useful and titrate it slowly. So I will say it's a good first add-on anti-epileptic.
Ma'am, I am Dr. Tanmay Pal. Actually, I have asked the question.
Yeah, I know.
So ma'am, actually, zonisamide has some action on the hepatic enzymes. It is probably a enzyme inhibitor, if I am not wrong. So if zonisamide, because of that enzyme inhibition, if it is added as add-on, so it might affect the action of other anti-epileptics, right? So that's
Agreed. See,
what is your take on that?
I agree. You can combine. You should not combine it with valproate because it is also enzyme inhibitor. Like we don't combine topiramate with valproate or even zonisamide with valproate. We can still combine either topiramate or even zonisamide with the sodium channel blockers, which are their enzyme inducers and it's an inhibitor. And also, we will say it's a broad spectrum anti-epileptic drug, like topiramate with multiple mechanisms of action. So useful, I will say, both in generalized as well as focal epilepsies, but I use it less.
Okay, and ma'am, I have another question. Both phenytoin and phenobarbitons are enzyme inducers.
Yeah, but if you look at the mechanism of action, one is a sodium channel blocker, another one is a GABA agonist.
Okay, that's why.
That's why they do. Patients do respond very well. It is one of the best combinations for people who come from remote places who cannot afford drugs more than 500 rupees per month.
Right.
And availability is another issue.
Phenobarbital is available, no, Sumit?
Is available.
No. With the newer drugs, availability
in the remote areas.
Apart from being expensive.
No, it's not only that. No, what I will say is it's very easy. You can give OD dose of both. Phenytoin is available as extended release, 300 milligrams, combined with 60 or 90. Compliance will be very good.
What about adding carbamazepine or oxcarbazepine with phenobarbital?
With phenobarbital. Yeah, you can stay. Yeah, because I was in the Jamana in 83 when I joined my medicine. And in 93, we had only phenytoin, phenobarbital. So we used a lot of combinations of carbamazepine with phenobarbital. People used to do well.
Okay.
But nowadays with this hi-fi, I will say, I don't know, with the so many newer generation. Now, the young generation who are coming now do not even know about phenobarbital.
Yes. It's a wonderful drug, but now people have probably given it up completely.
Yeah, recently
And
in the
the good
status
one,
epilepticus, I had to use a lot of phenobarbital to settle.
we still use it. Dr. Reenu Chaudhary, between brivaracetam and perampanel, what would be your choice as a first add-on in any type of seizures and why, particularly partial onset seizures?
Good evening, sir. Good evening, ma'am. Yes, I'm using both of these drugs, but I am pro perampanel as compared to brivaracetam. Perampanel, as we all know now, it has been approved for focal onset seizures, focal to secondary generalization, mono, as well as add-on therapy, and also as an add-on therapy for generalized GTCS seizures in the patients older than 12 years. So yes, I have used it, but the added advantage, which I think is its longer half-life, that is 105 hours in books, which is said. So because of long half-life, the patient compliance is good. And even if the patient misses the dose, there are very less chances of breakthrough seizures with the same. But again, a disadvantage for the same is we should be very slow on the titration schedule, and a close monitoring should be there for the side effect profile. So my preferred, or everyone's preferred time of dosing would be at bedtime, starting as low as 2 mg, no going faster than a week. You should be slow. If you see the side effects like sedation, dizziness, so you should be again slower than a week also. And with my experience, so apart from these focal onset, focal to secondary generalization, I have used this drug in 2 patients. Both were of epilepsia partialis continua. One was secondary to focal cortical dysplasia and other was secondary to DNETs. Both of them were having uncontrolled EPCs. And after failed attempts of 3 or 4 drugs, levetiracetam, lacosamide, carbamazepine, when I added perampanel, both of these patients did really well after a day, and they are still doing well even after 2 or 3 months of their therapy. So I think perampanel appears to be a promising therapeutic option in EPCs too. And till now, my all of patients, they have experienced reduced seizure frequency. They are like a few patients are seizure free, and as well as some patients have also experienced the longest pre-treatment seizure free interval also with perampanel. So the only side effect profile, that is like one patient had severe attack of dizziness and he dropped it. Otherwise, I think perampanel is a good option. But I would like to ask ma'am one question. Now they are saying it can be used as a monotherapy in focal onset seizures, or it can be used as an add-on therapy in GTCS also. Ma'am, sir, what is your experience regarding this?
Yeah, what I will say is, though it can be used as monotherapy, we should always follow the guidelines given by means we follow the AN guidelines or the NICE guidelines. So with that, still oxcarbazepine is the first drug of choice in children, carbamazepine in adults. So now it means it's better to do that rather than go for we need more evidence for the use of perampanel, means as monotherapy in patients with focal onset seizures.
Okay. And ma'am, any experience regarding using it as an add-on therapy and GTCS?
Yes, I have used it in some patients with difficult to treat, where you have a combination of GTCS with myoclonus with absences. It's useful. I have a few patients with juvenile myoclonic epilepsy where you have severe behavioral issues with levetiracetam, valparin, significant weight gain. They just don't want the drug. Then I have used perampanel and I could maintain them on monotherapy. So these are just a few cases, I would say. But I still find perampanel is a very useful drug in status epilepticus, especially once the first 2 drugs fail, you just load them with 20 milligrams stat, followed by maintenance of 10 to 12 milligrams daily. Maybe we can prevent our patients to go on to the ventilators so that it saves the money as well as the risk of infection.
Yes, ma'am.
So many other things. Yeah.
Thank you, ma'am.
Yeah.
Another point which is to be kept in mind is that perampanel is available only as an oral formulation, whereas brivaracetam is available as an injectable preparation, oral preparation, and a syrup formulation. So that is one convenience which is there with the brivaracetam, which unfortunately is not there with perampanel as yet. Yeah, so it's that way. And so my next question, just a moment. My next question is with Dr. Rishikesh.
Yes, sir.
What is your take on lacosamide as an add-on, and what would be your inhibitions in patients when you are trying to add lacosamide as an add-on in patients with partial onset seizures?
Basically, as a neurosurgeon, I find lacosamide very good. See, it is a one molecule lacosamide which was not used much. That's what my opinion is. And whenever there was for partial onset seizures, mainly we see what are there in head injury or post-operative patients, that is operated for tumor or something like that. So in those, after the preferred drug was levetiracetam, but for breakthrough, we used to use lacosamide. But then between last 2-3 years, lacosamide suddenly disappeared from our prescription. That's what I felt. And then when I realized, I started using this perampanel when it was with one company only. I think Ficompa was marketed. That's where I started using this for partial or refractory seizures, basically. So there were and pediatric patients who were on, I think, phenytoin and then levetiracetam, but still they had seizures. So in them, I tried Ficompa, which was only drug available that time for perampanel, and then 2 milligram, 4 milligram, and I extended it to 6 milligram twice a day. And then I could control them and then withdraw gradually phenytoin and levetiracetam. So I could use this as a monotherapy in those. And now my take is with availability of brevitiracetam, I'm using more of a brevitiracetam and perampanel combination in my patients. The only side effect which I find in 2 or 3 patients is that increased sleep. See, the daytime somnolence is increasing in these patients who are on perampanel. That is the only side effect I found. But most of the patients are doing well when you consider partial onset seizures in these.
Madam, I would like, Professor Rishikesh, I would like to draw Madam's attention on this combination of brivaracetam with perampanel. Both of them got a really a deadly combination, sir, because the suicidal ideations are there in both. Both have got a black box warning on suicidal ideations. You have to be very, very careful in combining these two. I just wanted to
even levetiracetam with perampanel,
brivaracetam and perampanel, when you combine, you have to be really assess the patients by any of the depression scales or ensure that he doesn't have, and keep monitoring it. Otherwise, all of a sudden, I find this suicidal thoughts, they suddenly spark and then end up in suicide.
No, we should not combine. I think
it's very. It is not. I think you should be very cautious, sir. I just wanted to.
Yes, absolutely.
Both have a black box warning for suicidal ideations.
Yes, absolutely. I agree with you completely. And a combination of two suicidal black box drugs would be definitely suicide. So my next question would be from Dr. Sai Satish. So lacosamide, are there any inhibitions in using lacosamide as add-ons? My inhibitions are that of old people, where we have observed some cardiac rhythm abnormalities, and Samir has pointed those out when he was with us. Unfortunately, he's left us now. So he was observant in this particular thing. So your take, Dr. Sai, on the arrhythmiogenic potential of lacosamide. I think Dr. Sai is no more with us. Anyway, so Dr. Sita, can you highlight this aspect of lacosamide?
Yeah, I agree with you, Sumit, but actually, I still find lacosamide is one of the very important and good molecules. In my practice, it has replaced carbamazepine because of the risk of rash. So I use it as that of carbamazepine. I still find carbamazepine is the best drug for partial seizures. Now I find lacosamide is the best drug. And among the second or third generation, it is the highest use. Like you said, in elderly, I prefer brivaracetam than lacosamide. Even when you are using in elderly, we need 30 to 50% lesser dose than compared to the young people. So even if you are using lacosamide, we can use 50 milligrams twice a day. as good as or 50 milligrams twice a day of brivaracetam. Though it has been shown, there is enough literature now to say that levetiracetam can be, even recently we had a lecture by Jacqueline French, who said that initially there were papers saying that there is a prolonged QT interval or a PR interval, or it should not be used in arrhythmias. But definitely there is no contraindication in people with arrhythmias. But consciously, if somebody has a history of arrhythmias, better to avoid it. That's how I will look at it.
Yeah, I agree with you completely. So I think we have had a very, very fruitful discussion. And may I request Dr. Lakshmi Narasimhan to kindly sum up the proceedings, and then we hand it over to the organizers for the closing remarks.
I would like to ask 1 or 2 questions.
Sure, please carry
on. In patients who were on levetiracetam and levetiracetam was not found to be effective, how likely is that brivaracetam will be effective in such patients? Because this was discussed during the presentation also, that in patients who are not responsive to levetiracetam, patients we can use brivaracetam. So how likely is it that that molecule is going to be effective, considering the same receptor efficacy, though the affinity is definitely high for brivaracetam?
Actually, if you look at the literature, it says the affinity is 100 times higher and efficacy is 10 times higher than levetiracetam. But definitely, I will say in our practice, I always use brivaracetam whenever the patient, 2 reasons. One is they develop side effects with levetiracetam, or it's not effective, or the patient says the tablet is too big, I'm not able to swallow. So every time, whenever I have changed, except for 1 or 2 patients who still continue to have behavioral issues, we could continue it with, I will say definitely it's more efficacious than levetiracetam.
Probably we have not changed because of lack of response to levetiracetam.
Yeah. No. Levetiracetam is still the king of the market.
And apart from that, we have been using perampanel as mostly, the studies reveal that perampanel has been more effective in seizure control in elderly patients than the younger patients. The seizure freedom has been seen more in elderly patients. Any particular reason for that?
With levetiracetam?
With perampanel.
No, perampanel.
With perampanel, the studies have shown that the elderly patients have shown a greater percentage of seizure freedom with perampanel.
Maybe it is a bias. It was studied in perampanel, but not studied with other drugs.
And in generally, and also with perampanel, the studies have shown that when it has been used in an early add-on, as compared to the late add-on, the early add-on time, the results have been better as compared to late add-on. So this could apply for any other molecule.
Any drug. If you look at lacosamide, it is 60% efficacious with non-sodium channel blockers, 30% is sodium blockers. I think it occurs with even clobazam.
Because probably when we are going up to the 3rd or the 4th drug, then definitely we are dealing with the drug refractory epilepsy and
yeah, it's epilepsy, not the drug.
Yes. Yes. Thank you so much, ma'am. Wonderful presentation.
So I think Dr. Lakshmi, may you kindly?
Yeah. Dr. Yatin.
Yes, sir.
Sir, I would just like to ask one more question. Actually, it is very similar to the case Smita just said. Yesterday itself, I discharged a young boy who had NOS and again polypharmacy. So patient is also on levetiracetam, on tapering doses of phenobarbital, and is also on perampanel. And just like sir said, this patient is now having a lot of aggression and is hitting the sister, his mother, and we have somehow discharged him yesterday after decannulation. But what could be the guidance of tapering down, and which anti-epileptic should be withdrawn first? Of course, in terms of aggression, in terms of behavioral side effects, suicidal tendencies, and that's one problem that is something which I would like your guidance on.
Yeah, may I, Sumit?
Please, ma'am, please.
Yeah.
No, especially when somebody has behavioral issues, first thing is we should avoid using all the 3 drugs, levetiracetam, perampanel, even phenobarbital. Yeah, but once they are already on, phenobarbital should always be tapered very slowly at the rate of per month. Whereas perampanel also should be tapered very slowly. But once there is aggression, what I will do is I will give him a loading dose of valparin and take off both the drugs. Possibly I will taper phenobarbital slowly, because it depends on how frequently the child is having seizures. So in such cases, the drugs which are favorable for cognition are oxcarbazepine or carbamazepine or lamotrigine with valparin, which will be very good combination in children because it covers all the seizure types. So if somebody has ADHD, because 30% of the children will have either behavioral issues or ADHD. So one should avoid even levetiracetam or even phenobarbital. Definitely perampanel should be avoided.
Yes, sir.
Thank you. Thank you.
Okay. All of you would agree that we had a wonderful discussion. Madam has elaborated on how do you choose an anti-seizure medication, especially as an add-on. And she also enlightened you that the various types of responses, the 4 types of ABCD types of responses, and how your seizure medications is going to influence the course of the disease. She also highlighted the possibility of one of this Martin Brody's article. She also said that always you stand a chance by adding another drug. So whenever the refractory seizures, even you are the 6th doctor to step in and then try something that might work out for the patient. So never, there's always, but only thing is try to be rational on adding the drug, and how you have to be rational. Madam has beautifully elucidated in her talk. Coming back to the hero of this entire symposium, perampanel. Perampanel is a wonderful drug with a unique mechanism action of AMPA, which is essentially a very good add-on. It's safe with acceptable tolerance limit with a black box warning on suicidal ideations and depressed patients. And ideally should not combine it with the drugs which have similar actions like brivaracetam and levetiracetam. Do not combine with enzyme-induced anti-epileptic drugs because they all increase the clearance of perampanel. Along with the non-enzyme anti-epileptic drugs, it's fairly good. And it has its unique, perampanel has got a unique role. And there are a lot of experiments are going on its role in Parkinson's as well as in ALS by being an AMPA antagonist. I think, and headache. So there is going to be the other areas where it's going to come out with its own roles. As on date, it's another good weapon in your armamentarium. Thank you for your attention.
Thanks, Dr. Lakshmi and Dr. Sita. I hand over to Michael to take things forward. Mr. Michael, are you there?
Good evening, doctors. On behalf of INTAS Aestheta Division, I would like to thank you, Dr. Madam Sita Lakshmi, for your very practical and insightful presentation on the guiding principles to choose the first add-on anti-seizure drug in epilepsy management. I would also like to thank you, Dr. Lakshmi Narasimhan, for chairing this webinar with your crisp take-home messages wherever needed for the benefit of the practicing physicians at large. Finally, I would like to thank the panelists, Dr. C. Ramesh, Dr. Nirav Mehta, Dr. Samir Arora, Dr. Sukriti Chauhan, Dr. Tanmay Pal, Dr. Dinu Chaudhary, Dr. Rishikesh, and Dr. Yatin Sagvekar for attending today's program, and your clinical experience sharing have helped enrich this program and make it a grand success. Once again, thank you to all. Good night, and wish you a very happy and safe days ahead. Thank you very much.
I wish all of you a very happy advanced New Year wishes. Wish you a very, very happy, healthy New Year to all of you who have attended this webinar. Thank you.
Thank you very much. Thank you. Thank you. Thank you.
Thank you.
So same to you.
चलो रोहित ठीक है चल बाय रिकॉर्ड क्लोज हेलो रोहित हेलो Hello. Hello. Rohit. Hello.